but only 7% reported to a formal source. Like 2% in India and Southeast Asia, and 14% in Latin America and Caribbean. And it's not moving. Yeah. The cycle of abuse can be from pre-birth, infancy, girlhood, adolescence, and adults. These are all the phases where there can be an abuse. So in pre-birth, we all know that there's sex-selective abortions, effects of battering on pregnancy and childbirth, or female infanticide in infancy, physical, sexual, psychological abuse. And when it comes to the young girls, it is child marriage, female genital mutilation, physical, sexual, and psychological abuse, incest, child prostitution, and pornography. And in adolescence, it is trafficking, honor killing, partner violence, marital rape, dowry, murders, abuse of women with disabilities, rape, sexual harassment, forced prostitution, pornography. So in older women, it's forced pregnancy, acid throwing and date rape, economically caused sex, incest, sexual abuse in the workplace. So 20% of women experience child sexual abuse. And about 40 million women are married before 18 years, and 50% of child marriages occur in South Asia, and 125 million women in 29 countries in Africa and Middle East experience female genital mutilation. So 1957 women in Pakistan killed in the name of honor between 2003 and 2007, and 11.4 million women trafficked globally, and 30% experience intimate partner violence, and 7% sexually assaulted by someone or the other than the partner. So what are the health impacts of gender-based violence on an individual? So it can be physical or reproductive. When it comes to physical, it is acute physical, chronic physical. In acute, it is injury, shock, disease, infection, weight loss or gain, regressive behaviors, not eating or eating too much, or chronic is disability, chronic pains, gastrointestinal disorders, eating disorders, sleep disorders, and chronic fatigue. Reproductive is, it can range from anything like unwanted pregnancies, miscarriage, unsafe abortions, STIs including HIV, menstrual disorders, pregnancy complications, and gynecological disorders. So effects beyond the individual survivor, it can be beyond the individual survivor, it can be to the children, families, or the community also. So when it comes to the children, it is higher rates of infant mortality, behavior problems, anxiety, depression, and attempted suicide, poor school performance for these children, physical injury or health complaints, experiencing or perpetrating violence as adults, because they grow up in such an environment, they think it is right. So when it comes to the families, it is fractured family relations, safe care. If abuse happened in home, safety is very important. And housing instability, co-occurring violence, poorer collective health, and coping also. And the community and society's costs of services incurred by victims and families, like for health, social, and for justice also. Loss of education and potential development and contribution by children as they become an adult. Perpetration of violence in community and higher crime rates, burden on safety and justice sectors. So where and how do violence and HIV effects intersect? HIV AIDS itself intersect. So direct transmission through sexual violence, type of sexual exposure, presence of other STIs, and the degree of trauma. Indirect transmission through sexual risk-taking. Violence is linked to increased risk-taking, taking multiple partners and non-primary partners also. And indirect transmission is through inability to negotiate condom use. Women find it difficult to suggest or insist on condom use in face or threat of violence. So when it comes to intimate pathways and health effects, intimate partner violence, physical trauma, Physical trauma, psychological, or fear and control. So when it comes to physical, it is injuries to the musculoskeletal, soft tissues, genital trauma, and others. And psychological is mental health problems, which can lead to alcohol or other substance abuses, and which in turn can lead to cardiovascular or non-communicable diseases like cardiovascular, hypertension, diabetes, because of the stress. And the somatoform is like psychosomatic is irritable bowel syndrome, chronic pains, etc. And fear and control is limited sexual and reproductive control, lack of contraception and unsafe sex, and healthcare seeking, lack of autonomy, difficulties in seeking care and other services, which can lead to perinatal and maternal health, low birth weight, prematurity, pregnancy loss, etc. And sexual and reproductive health also, like unwanted pregnancies, abortions, HIVs, STIs, and other gynecological problems. So 42% of women who have experienced physical or sexual violence at the hands of a partner have experienced injuries as a result. And mental health, twice as likely to experience depression. Almost twice as likely to have alcohol use disorders. And 16% more likely to have low birth weight babies. And twice as likely to have an abortion. And 1.5 times more likely to acquire HIV, and 1.5 times more likely to contact syphilis infection, chlamydia, or gonorrhea. And 38% of all murders of women globally were reported as being committed by their intimate partners. 4.5 times as likely to attempt suicide. So we'll now have a small quiz, and you can put your answers in the chat box. So the first is the statement: intimate partner violence is more prevalent among poor women and girls. Is it true or is it a myth? Is anyone seeing the chat box?
Yes, I'm having a look.
Yeah.
So for no comment. Yeah. There are comments now. It's a myth.
Yeah. The answer is it's a myth. Studies show that gender-based violence can happen among women of all socioeconomic, educational, and racial backgrounds. Violence may affect our peers, colleagues, and friends. They may be sitting next to us. The next is, in some instances, especially when it is not severe, beating by a husband can be an effective form of discipline if the woman is acting inappropriately. What do you think, all of you? Is it true or is it a myth? Think. So gender-based violence is a serious human rights, health, and development issues impacting survivors, their families, and the health and development of entire communities. So this is according to the studies. Majority of sexual violence against women and girls is perpetrated by strangers. Is it true or is it a myth? Some answers are
most of the answers are myth.
Yeah, some more answers. Anyway, it is a myth. Studies consistently show that most women who experience sexual violence are abused by people they know. Often the perpetrators are those they trust and love. Globally, women's homicides are 6 times more likely than men's to be committed by an intimate partner. It is safer for a woman to leave a relationship with an abuser than to stay. What do you think? Is it a myth or is it true? Violence often continues, may even increase after a woman leaves a partner. In fact, a woman's risk of being murdered is greatest immediately after separation. Anyway, this is according to the studies. Gender-based violence is a serious human rights, health, and development issue impacting survivors, their families, and the health and development of entire communities. So please, all of you, do a pre-test and a post-test and feedback for you all to get the certificates. Thank you.
Lovely talk, ma'am. I think the pure insights and in overview we've got of all the program, what we are going to do it today. And moving on ahead in this program, I'm going to talk upon how to approach a woman facing violence. Coming down to the second step of it. I am thankful to Dr. Shanta Kumari Madam, Dr. Kiran Mai and Dr. Ajay, who has been the backbone of this whole project and helping us and guiding us all through for this flagship program of our President Foxy, Dr. Shanta Kumari. Why do we survivors not seek help? They require to seek help. The victims have a blaming attitude of the providers. Fear of shame or stigma could be associated. Fear of no confidentiality, inappropriate services or services that are not useful or prioritized by the survivor. Perceived impunity of perpetrators. Or if there is any other reason, kindly put it in the chat box so that we are more updated with it. Who all can play a role to help the survivor, and how can they play a role? Either it could be the family or the service healthcare provider or the community, which would help the individual or the survivor to sail through in his life ahead. There's a role of the family, the friends, and the community. The recovery from the violence dependent on extent of the support received from the loved ones, the health of the professional or the engaged with the family, and discuss the ways of promoting survivors' well-being which is required. It should be discussed with all the caregivers that the survivor should not be held responsible for the assault. Child sexual abuse, the parents may experience an anger, confusion, guilt, or self-blame can be there for them. Reiterate that it is the perpetrators who misuse their position, which is important. We as healthcare providers would like to support all the women are likely to seek health services at some point of time in their life. The healthcare providers are often trusted by the woman and serve as a role model in the community. Violence is an underlying cause of injury and ill health. The role of healthcare providers is to a greater extent to create an enabling atmosphere and establishing the trust with the GBV patients. Speak to the survivor in a private space. Recognize their courage in reaching you as they have overcome several barriers. Recognize the dilemma facing by the survivor in reporting violence. Do not label non-reporting to police as a false case. Assure the survivor that the treatment will not be compromised. Inform the survivor of available resources or the legal rights so that they can take an informed decision. We as healthcare providers can facilitate demystification of the medical procedures. So we should prepare the survivor for an internal examination, explain the various stages of examination, which is very important, and communicate about the need for the referral release for the X-rays, the ultrasound, the age estimated among the others, and all the rest of the procedures, whatever has to be done. The role of the healthcare provider is to address the survivor's emotional factor, recognize the survivor may be present or varied emotions, encourage the survivor to express her feelings, encourage the survivor to seek crisis counseling, assess the suicidal ideation, make a safety assessment and a safety plan. Involve the family and friends in healing process of the survivors. What we can say to all these survivors, take your own time, share only what would you like to share. I can imagine that must have been really hard. Take a tremendous amount of strength to share what is happening to you. How do you think we can help you? You are not alone. These are the few statements what we can do. The practical approaches is a solar approach, what we need to give to our patients. Solar approaches The sitting position is important. The open posture, leaning forward, eye to eye contact, which is important. We need to be more relaxed. Supporting GBV survivors using the LIFES approach is the another aspect. The LIFES approach is L stands for listening, I for inquiry, V to validate, E stands for enhanced safety, S stands for the support. L is to listen. Ideally, whenever we are listening, our eyes need to be open and give the patient undivided attention. Ears truly hear all the concerns. Heart is give it the caring and respect we need to do it. And ask all the questions to the patient which are open-ended, the focused, and just not ask the questions which are having the answers of yes or no. A good body posture or a language with eye contact is most important. Avoid leading questions and compounded questions to these patients. There are few do's and don'ts in counseling. How to act. Be patient and calm. Let the client tell her story at their own pace. Don't pressurize her to tell her story. Let her know you are listening, though verbal or non-verbal clues or example, nod your head and say, Maintain a gentle and appropriate eye contact. Don't look at your watch or speak too rapidly. Don't answer the telephone or look at the computer or write anything when you're listening to the patient. Our attitude makes a lot of difference. Acknowledge how she is feeling. Don't judge what she has or has not done or how she is feeling. Don't say you shouldn't feel that way or you should feel lucky you have survived. What we are supposed to say is give her the opportunity to say what she wants. Ask her, how can I help you? Don't assume that you know what is best for her. Encourage her to keep talking if she wishes. Ask her, would you like to tell anything else? Don't interrupt. Wait until she has finished before asking another question to this patient. Allow for silence. Give her some time to think over and open up. Don't try to finish her thoughts then and there. Stay focused on her experience and on offering support. Don't tell her about someone else's story or talk about your own troubles. Acknowledge what she wants and respect her wishes. Don't think and act as if you must solve her problems then and there for her. I stands for inquiry. Ideally, phrase your questions as an invitation to speak. Ask all the open-ended questions instead of your yes and no type of a question. Check your understanding by restating what he or she has told. Reflect back to the client the feelings they express. Explore as needed. Ask for clarification if you don't understand. Help her to identify and express her needs and concerns. Sum up what she has expressed. The leading questions what we can ask is what you want to say. What would you like to talk about? How do you feel about that? You mentioned that you feel very frustrated. It sounds as if you're feeling angry about that. Could you please tell me more about that? Can you explain that again, please? Is there anything that you could need or concern about? You seems to be saying that. V stands for validate. Validate does not mean to try and verify the survivor's story. For example, though interviewing the alleged perpetrator or witnesses, this is not safe, appropriate, ethical, or recommended. Show that you understand and believe them. It is not your fault. You are not to blame. You did the most important thing you could do in that moment. You survived. Help is available. No one deserves to be hit by their partner. You are not alone. Unfortunately, many others face this problem. What happened has no justification or excuse. Your life, your health, you are of value. Everybody deserves to feel safe at home. These are a few of the questions, leading questions, what we can tell. A word about empathy versus sympathy to create the boundaries. Sympathy is a personal, emotional identification with the survivor's experience and implies that the service provider feels sorry for the survivor. It is an emotional state that leaves the service provider vulnerable to over involvement and can take power away from the survivor. It is identifying with the survivor's experience through your own shoes. Empathy implies intellectual or personal understanding and realistic professional distances. It involves compassion, objectivity, and leaves room for empowerment of the survivor. It is the attempt to put oneself in the survivor's shoes. Dealing with the emergency situations during your approach, which is the lives, is important. The challenging issues when dealing with a survivor who is in immediate danger. If the survivor tells you that their abuser has threatened to harm her, what should we do? Put your thoughts in the chat box. We would like to listen. Few of the ideas like concentrate on the questions about the safety risk, but only when there is privacy. Ask if survivor has a safety plan in place in case she needs to flee. Discuss potential strategies for being able to leave her situation safely. Provide a referral to a GBV expert agency for additional help if possible. There are few challenging issues when a survivor faces. It could be anything. Be able to recognize the signs of depression and suicidal risk is important. Do not be afraid to ask, are you having any suicidal thoughts? If the answer is yes, then do take it seriously. Do not leave the suicidal survivor alone if there is an immediate danger. Always consult a supervisor about how to refer or manage a suicidal behavior. Never make a decision on your own. This is for your own safety and well-being. Provide referral to the GBV expert agency for additional help if possible. Ignoring the violence can do more harm. Let's understand what the provider's behavior and what could be the possible consequences for that. Blames or disrespect women or the girls could lead to inflicts additional emotional stress or trauma. Doesn't recognize a GBV behind the chronic or recurring conditions, the woman receives inappropriate or inadequate medical care, fails to provide a post-rape care or additional GBV, a family planning or STI or HIV care, then unwanted pregnancies, STIs, HIV, unsafe abortions, and more violence can be there. Breaches of privacy and confidentiality could lead to the partner or the family member becoming violent after overhearing the information. Ignoring the signs and the fear of emotional distress, the woman is later injured, killed, or commits suicide. So we need to be more open to it and understand what the patient wants from us. The doctor helped me feel better by saying that I don't deserve this treatment. And he helped me to make a plan to leave the house the next time my husband became violent. This is how the patient should feel. A warm referral practice helps the woman reach further care. There are various mental health support system links, which we are going to tell you in the later half of the program in depth. The healthcare providers, the psychosocial support system is there. Then the legal support system is there. The justice is in place. The security of the GBV patients are in place, which we're going to learn in the later topics. But do remember, pre-test you all have given. The post-test is most important to get a certification and to become a trainer. Do remember to give a post-test after this program. Over to you, Ajay sir.
Okay, thank you so much once again, Rakhi, for doing this. I know it was you have something else to attend to, but I really appreciate all the 3 days that you have been here, taking and walking us through all of this. Over to you, Vindhya, for your next topic. And there's a hand been raised by Kritika. We will take your question after this session, please. Thank you. Yeah, we can see your presentation. Yeah. You're on mute right now.
Yeah.
You're on mute.
Yeah.
Yeah, now you're okay.
Once again, thank you, Ajay. And this is again a very important subject, the effects of wow on pregnancy and newborn. So, have you ever seen a patient in your OPDs who have been victims of violence or abuse? I think we all remember some of you. We go back to our practice for the last 10, 15 years or 20 years. We can really remember some of the cases. How do they present? How have you diagnosed? What are the common clinical presentations? Can you recollect a case? So causes of maternal death can be so many. So they can be all these, but most of the time when we say behind these, the maternal death, there may be a violence also. They came inflicted violence many of the times. So high level of violence during pregnancy. So a woman from Peru has said, he hit me in the belly and made me miscarry 2 babies. I went to the hospital with heavy bleeding and they cleaned me up. This is actually not only in Peru, but this can happen anywhere in our other countries and even in India. So these are the cases which I will tell you briefly. A primey with PROM, prolonged obstructed labor, presented with a rupture uterus shock, and there was maternal mortality. So the history revealed later that history of brutal kicking on the abdomen by husband and pushed violently, falling on a sharp object, and death was due to violence. The second case is gravida 3, para 2, 28 weeks, previous 2 cesareans. She had an antepartum hemorrhage, shock, and placenta accreta. Hysterectomy was done. 10 bottles of blood transfusion was given. There was bladder involvement also. And what precipitated bleeding? Husband kicking on the abdomen. The case 3 is a woman with severe preeclampsia and unconscious, eclampsia with CVA leading to maternal mortality. So death was due to eclampsia. So actually violence by husband, postmortem revealed fracture of the skull and cerebral hemorrhage. Direct death due to violence. So hidden violence masquerading as maternal disorders. So case 4 is gravida 3, para 2 with the previous 2 cesareans, a full-term pregnant. A rod was implanted for a fractured femur and a hip joint, collapsed in front of the hotel and brought to the hospital in 108 ambulance in active labor with severe hypertension. Emergency cesarean was done and consent was given by the RMO. She didn't have any attenders. So she was pushed from the 2nd floor 3 years back, now abandoned in labor. Case 5 is gravida 3, para 2. She has no living children with previous 2 cesareans, 36 weeks, with severe anemia. So both times history of physical violence, kicking on the abdomen brutally by husband, followed by loss of fetal movements. 3rd pregnancy, parents brought her home, transfused blood, and then a cesarean was done, and the baby was alive and the mother was alive. So the other case is gravida 6, para 2, living 2. He had 3 abortions, 2 previous cesarean sections, 3 induced abortions, acute hemorrhage, shock, sepsis, incomplete abortions. So severe form of physical, emotional violence, forced abortions, abandonment. So the history brought out only by screening. Received 4 transfusions. See this domestic violence, she was hit and then there was injury on the face and then stab injury on the abdomen, led to a sharp injury on the uterus where they had to do a laparotomy and then they had to close the rent. It can be so brutal. Stab injury, husband inebriated, in an inebriated condition, laceration on the face, perforation of the uterus, IUFD and laparotomy and rent repair was done. So we as obstetricians and gynecologists, we are special stakeholders in women's health, and we are in a very unique position to assess and provide support for women who experience violence because of the nature of the patient and the physician relationship. They usually, these women, because we are women, they come to us for everything. So we have the opportunity from adolescence to the adulthood, many opportunities, interventions that can occur during the course of their lifetime, from adolescence, in pregnancy, family planning advice, annual examinations and other conditions, problems for the women. So how to elicit history? We can ask indirect questions. The following may be helpful. Is everything all right at home? Are you getting on with your partner? These are the questions. We can just lead in questions. And these are the screening tools. There are abuse assessment screening, humiliation afraid, that is HARP, HIT. These are all the tools which we can use to take the history. Use them for that. And the WHO recommends that all health professionals be trained in first-line response to family violence. The steps are to listen, believe, inquire about needs, validate the person's experience, enhance safety, and offer ongoing support. So universal screening or routine inquiry, that is asking all women at all healthcare encounters about IPV, is not recommended. We need not ask in all conditions. So however, the WHO guideline identifies antenatal checkups as a setting where routine inquiry could be implemented if providers are well trained on a first line response and minimum requirements are met. So many of the countries, they do have in their antenatal screening and chart asking a question about this intimate partner violence. So we should ensure safety. The evidence on benefits and potential harms of clinical inquiry and subsequent interventions is lacking or uncertain. A minimum condition for healthcare providers to ask women about violence is that it must be safe to do so. That is, the partner is not present. And that identification of IPV is followed by an appropriate response. So detailed guidance on responding to IPV and sexual violence against women can be found in 2013 WHO clinical and policy guidelines. We can always look up. So please do your post-test and feedback for you to get the certificates. So many women in many parts of the world speak the same language, the language of silence. This was said by Anasuya Sen Gupta, and it's up to us, obstetricians and gynecologists, to be the voice of the silent victim. Thank you.
Thank you so much, Vindhya, once again for doing such a wonderful job. And you have been at it, continuously for the last 3 days. Thank you once again.
I'm knowing by heart all these slides. So before the slide comes, it's in my mind.
Yeah, I know how it feels. And, many times what happens is a huge round of applause to all the faculty who have been doing it for the last 3 days. Because, at the end of the day, it does get a little fatiguing because you're speaking the same thing again and again continuously for 3 days. So thank you very much for doing this. So what we have done is we have walked you through the first module in which we have given you the complete overview. And then we have talked about, what are the various ways, how to approach a woman facing violence. And the last session was a very interesting one because in this session, we walked you through several, case studies, almost 6 of them, where the woman, and it led to a maternal mortality, and it was assigned and attributed to something which was related to a clinical sign. However, on further probing and further analysis of in depth of the same, one realizes that at the bottom of it was some or the other kind of violence which led to the situation that the woman was. In one of the cases, the neonate did survive, whereas in most of the cases it resulted into maternal mortality. With that, I'm happy that Deepa has been able to join us. We were hoping, she does, because she was in an emergency. And thank you very much, Deepa, for coming in, and most welcome to join us on this session today. And after talking all of these aspects, and another important issue that we need to address and talk today about is the mental health issues, which is what Deepak will be walking us through. Thank you so much, Deepa. Over to you.
Thank you, Ajay. I'm so happy to be here, first of all, for the common cause of Stop Violence Against Women, our brainchild of our Foxy beloved president, Dr. Shanta Kumari. And I'm so happy about all the volunteers joining hands with us for this training program. Welcome, everybody. I'm just sharing the screen. It says a host has disabled participant screen sharing.
Madam, I made you co-host, madam. I gave you access.
Okay. Just a second. Are my slides visible?
Yes, ma'am.
Yeah, they are. They are. We just need to make it full screen. That's all.
Now is it okay?
Yes,
ma'am.
So first of all, I'd like to congratulate the entire Dheera core team for developing such wonderful modules to educate all the doctors as well as students and in the schools as well as colleges. Special credit to Dr. Kiran Mai and Mr. Ajay, who has been really instrumental in rolling out this project very successfully. And this module has been developed by me and Dr. Ramani Devi, our past Vice President Foxy. So going on to mental health issues in women who suffer violence. My slides are not moving. One second. Can you see my slides, Ajay?
Yeah, we are able to do that. Thank you.
So let me just start off with presenting a real case report that we have come across. This is a 26-year-old woman who was brought to the hospital with complaints of sudden abdominal pain. She was 28 weeks pregnant, and she's been married for 1 year, and this was the first pregnancy. She was a booked patient on regular antenatal checkup, non-diabetic and non-hypertensive. On examination, she appeared to be very depressed and very withdrawn. Her vitals were stable. Uterus was 28 weeks. It was irritable, but FH was normal. Vaginal examination was unremarkable. On inquiry, she came out with a history of being beaten by her husband. I think almost all of us would have come across such patients. Wife battering happens very often, and it's very clear that pregnant women are more vulnerable. They can be subjected to violence, and both the mother and the fetus can be affected. And so the mental effect is more, in fact, for the woman who is pregnant because she also cares for the child. So what are the details to be gathered from this patient? I'd like some inputs on the chat box if you're all in for this. You can write down some suggestions about what we will be asking this patient, whether we need to inform police or not, how to counsel the patient, what are the problems the patient can come across, family counseling is required or not, any drugs that can be suggested, and the aftermath of intimate partner violence. So anyone on the chat box? Not yet. I hope everybody has access to chat box. Yes. Okay, we will just move on. So actually, mental health is goes hand in hand with physical health for all women, and especially for patients who are pregnant and subjected to violence. And we need what is called as a triad of consultations. The first point of contact is usually the obstetrician. Whatever happens in pregnancy, the first point of contact, the patient comes to us. So we have a huge responsibility of caring for this patient who has been like subjected to violence. And the psychologist and psychiatrist are additional counselors, and psychiatrists are additional team that have to be formed for appropriate care. Why mental support is actually needed? Because post-traumatic stress disorder, which is perceived as life threats or injury, is very common in these women who are subjected to violence. Hypervigilance is also very common. Mood disorders are very explicit. Most of them are depressed, and they can even have suicidal tendencies. They can always take to substance abuse, alcohol, drinking, or smoking, just to circumvent the issue of violence and discrimination. Sexual disorders are common in these patients. Phobias are very common. Functional GI symptoms, feeling of butterflies in the stomach, some kind of vomiting sensation, loose stools. These kind of anxiety symptoms are pretty common. Dissociation symptoms are also very common. They don't feel like mixing with other people, either in the family or in the social network. They are always withdrawn, something they want to hide from the rest of the world. And that is why they're also socially withdrawn. So what is the role of obstetricians? We are actually the first point of contact for most of these women, because they feel that they have consulted us for some other reasons, and they feel very comfortable when they come to us. So we have to give them the best care, empathetic care that is required. First of all, it is important to do a risk assessment. What is the frequency of the violence the person is subjected to? What is the severity, and what is the chronicity? Is it just now happening, or it's been repeatedly happening for quite some time? Is it very often happening? And then there is a definite need for assessing the safety from further assault from the partner. They also need psychological screening for any suicidal tendencies or any danger assessment. The partner may be threatening to harm them or kill them, or do harm to the baby in case of a pregnant woman. So these are the things that need to be first assessed. And it is also important to assess domestic homicide risk. Like I said, the partner may be indulging in violence, especially sometimes this happens in many women in the rural network, especially if they have already carried 2 or 3 girl children, and then they're in for the next pregnancy. Then there's a lot of anxiety in the family. So what are the danger signs you will need to identify and treat these women who are subjected to violence? First of all, as I said, frequency of the violence that is being inflicted upon them. The presence of severity of injuries. Morbid injuries means the situation is really threatening for the life of the woman and her baby. We need to develop a solid networking and support system for her. Alcohol misuse. The patients may take to alcohol addiction as in order to forget or circumvent the problem. Threatening to kill. The partner may be actually threatening to kill the woman. Sexual violence. Even in marriage, we know nowadays that no means no. If the woman doesn't consent to sex, she has every right to say no. So sexual violence, they may be subjected to suicidal ideation in women. We always have to be vigilant, and we always have to ask them if there are any ideas about a suicidal tendency. It does not mean that once we start asking, they will develop such kind of ideas. It is our duty to evaluate how deeply the woman is affected, and any access to weapon, especially the person who is inflicting the violence. Does he have access to a weapon? Is he trying to harm the woman physically? And morbid jealousy in the partner. This also we have seen in working women, especially if they are earning more, or in such patients, you find that the partner also feels jealous and takes to violence. So what are the signs that we need to look for that require hospitalization of these women? So first of all, severe medical injuries. She may be bleeding, she may be having bruises, her baby may be at risk, she may be having a vaginal bleeding in pregnancy, she may be having abdominal cramps, etc. So to evaluate any medical injuries, we may have to admit this patient. Any suicidal thoughts, feeling of loneliness, having suicidal thoughts, homicidability. Is there a threat to the real threat to the life of this woman? If she goes back home, is there a possibility that the man can kill her? So we have to assess the risk of homicidal attitude and dissociative or psychotic symptoms. Some women may develop severe depression and dissociative symptoms. So they have to be identified and hospitalized for better support, mood instability, and affective dysregulation. Some of them may be breaking into crying spells. Some of them may be very emotional when they talk about the incident. Some of them may be withdrawn. They may. So we have to identify this whole spectrum of problems with mood instability and affective dysregulation. Self-destructive behaviors. Some of them may take to, they may get frustrated and they may take to self-destructive behaviors, inflicting wounds upon themselves or as a trying to show a threat to the person who's inflicting the violence. So self-destructive behaviors and serious threat to the patient's life for any reason. So these are the situations when you need to hospitalize the woman in order to give comprehensive care. So an individualized multidisciplinary treatment strategy has to be evolved and developed to handle this kind of patient. First of all, primary treatment modalities include for the safety assessment, risk of suicide and danger assessment to know the extent of the harassment, miliotherapy, mood stabilization by appropriate counseling methods. Some of them may need medication and medication like antidepressants or anti-anxiety drugs. It can be even if they are psychotic, if they're having psychotic issues, antipsychotic medication may be required, mood elevators could be required. It's very important to give a psychosocial support for this patient because it's both psychological as well as medical support. In most centers, there is a need for rape kit, photo documentation, and reporting legal concerns. We have to learn this. They will be talking about all these in the next few topics. So we have to have more and more of trauma recovery clinic. This is a clinic that handles patients with violence inflicted on them on a comprehensive basis with appropriate networking systems in place. So most there is a need for trauma recovery clinics in most places in order to handle them appropriately. The objectives of this clinic could be to enable survivors to come to terms with trauma, reclaim their lives by reducing emotional symptoms of trauma. They may be actually being haunted by the thoughts of being inflicted, harassment being inflicted on them. They may be having repetitive insomnia and repetitive recollections of bad episodes. So we have to reclaim their lives by reducing the emotional symptoms of trauma. We have to help them enhance their self-esteem and resilience. Most often we find that these women who are subjected to violence, they lose their self-esteem. They feel worthless, they feel they are unable, they are helpless, they feel they are powerless. So we have to do something to help them increase their self-esteem. And it's very important to improve social support, prevent re-traumatization. We have to see how we can prevent further episodes of violence in their milieu. We have to conduct awareness and capacity building programs for psychologists and counselors. We can have such trauma recovery clinics in any multidisciplinary centers, which is the need of the hour, as I already said. For example, the first clinic I think was started in Nimhans in 2014. And unless we have such comprehensive clinics, we cannot give them appropriate comprehensive care. So Coming to the psychosocial impact of violence, most women develop feelings of helplessness. Is the most common mental effect that they have. They feel helpless, they feel powerless, they feel they are unable to do anything in that situation. There is a progressive erosion of confidence and self-esteem caused by abuse. As I already said, there are feelings of guilt. There are feelings of guilt, shame, and isolation that the other person is overpowering them. There is sometimes paradoxically there may be a traumatic bonding, paradoxically strengthening the emotional ties to the perpetrators. So we never know how the person who is affected will react. So there may be paradoxically a traumatic bonding, physical separation due to increased risk of homicide. The woman may want to leave home or go somewhere else. So there is a risk of physical separation and its consequences. There is a decrease in coping ability in all these victims. Particularly, all these happen when there are repetitive episodes of violence. So the second person who steps in is the role of a psychologist. The psychologist next to the obstetrician and gynecologist plays a main role in treatment, especially in post-assault psychotherapy. Cognitive behavioral therapy is recognized as the appropriate exposure therapy in women who've been already exposed to violence. A variant of cognitive behavior therapy is when we help the victim to emotionally process assault by decreasing fear to memories or cues of the event. Like I said, many women develop insomnia, anxiety, etc. when they think about the incidents. So getting them out of this fear is very important. And there could be a brief trauma-focused cognitive behavioral therapy. This is a skills training in effective and interpersonal regulation, what is called as TARE. It involves psychoeducation about the impact of trauma on emotions and relationships. Emotion regulation skills, that is, you help them streamline their emotions. Effective expression of negative emotions, you help them get out of negative emotions and come out with some positive attitude towards life. Interpersonal skills related to appropriate assertiveness, because they lose they feel they are powerless, they feel they are helpless. So it's important to make them more assertive. Development of flexibility in regard to interpersonal expectations, actions, and reactions. Treatment also includes recognition of achievements during the treatment and exercises in self-compassion. It is always good to give them some rewards or recognize their achievements, saying they are doing really well, they've come a long way, or their ideas are good. It is good to boost their morale by giving them positive comments. Coming to the next modality of interpersonal psychotherapy. Interpersonal psychotherapy has been shown to be an effective non-exposure based treatment for post-traumatic stress disorder that most of these women develop. Many post-traumatic stress disorder symptoms reflect interpersonal difficulties such as emotional withdrawal from relationships and individuals. Interpersonal deficits, there is persistent loneliness. They may feel lonely all the time, sometimes resulting in interpersonal hypervigilance. All the time they are thinking about these episodes and when it is going to recur. So interpersonal psychotherapy actually consists of also newer psychotherapies like cognitive processing therapy, eye movement desensitization reprocessing, hope, otherwise known as helping to overcome post-traumatic stress disorder through empowerment. It is important that you don't, the service provider should not impose his or her ideas on the victim. Rather, you give them the appropriate knowledge and cognitive therapy so that they feel empowered on their own. Relapse prevention and relationship safety. These are the components of interpersonal psychotherapy. Women experiencing intimate partner violence related depressive disorder or alcohol disorder should receive mental health care as per WHO Mental Health Care Action Program Intervention Guide, which was passed in 2010, delivered by healthcare professionals with good understanding of violence against women. So cognitive behavioral therapy and eye movement regulation interventions delivered by healthcare professionals with good understanding of war are recommended for women who are no longer experiencing violence, and who are suffering from post-traumatic stress disorder. So these are the interventions of comprehensive psychological therapy. These are the WHO recommendations for depression and other emotionally or medically unexplained complaints. People, we can give them antidepressants, we can give them benzodiazepines if they are having insomnia. Drugs like fluoxetine are very useful, tricyclic antidepressants or mood elevators like fluoxetine. Treatment should be continued for 9 to 12 months after recovery so that they completely come out of this. There is a brief structured psychological intervention in the form of interpersonal therapy and cognitive behavioral therapy. Relaxation techniques, how to train them to relax, and also physical activity. Psychological support after recent traumatic event in the form of psychological debriefing, psychological first aid in terms of acute distress. So it's also important to involve men in group treatment therapy. And we have to encourage men to take personal responsibilities for violent behavior. We have to challenge attitudes on belief around the use of violence in a relationship. Men have to be told that what they are doing is not right, and they will not be tolerated. And also repetitive actions need to be curbed. Developing skills for reacting non-violently to others. They may be by nature or by because of psychological or some environmental issues. They may be they may not know how to react non-violently. So they should be taught about skills to react non-violently to others. We have to increase the awareness of dynamics involved in the use of violence. So men group treatment therapy is a very important inclusion. So to conclude, mental health issue is an issue in violence against women affected who are inflicted with violence, and thus needs to be addressed along with physical health, which is a very important component of treatment. Thank you so much for patient hearing.
Thank you so much, Deepa. You've touched upon a very important topic, and it's critical for us to be able to appreciate this bit as well. With that, we come to the next topic of presentation. Unfortunately, Aruna has not been able to join us because she's stuck in a emergency, as what I understand. But Aruna did take this session 2 days back, where we had another TOT. And can I request Sriman to please play her video on behalf of Aruna, please, on the same topic? Yeah, thank you.
My screen?
Yes, we can see you. We can see the screen now. Thank you so much. Go ahead. Yes, please.
Yes.
Yeah. So after Vindhya Madam, Dr. Raki and Dr. Ramani Devi Madam speaking on so many issues, what is war, how to approach a woman facing violence, effects of war on pregnancy and newborn. Now, after mental health issues, women who suffered violence, I'm going to talk about challenging issues when dealing with a survivor who may be feeling hopelessness, having suicidal thoughts, or in harms or a negative way. And what should you do? What should we all do when we face such situation? Being a gynecologist, one of our patients comes to us to our clinic saying that she is in a lot of pain because her mother-in-law is constantly pressurizing her that she must divorce her husband because she is unable to bear children. She feels hopeless and wants to give up. This is a very sad situation. What would we do? And what do you want to say something or just keep quiet or ignore? Please put your answers in the chat box. Okay, about few ideas. What are we supposed to do in such a situation? Be able to recognize the signs of depression and suicide risk. Yes, we have to be very sensitive towards the women. Do not be afraid to ask the direct question, like, are you having thoughts of suicide? Are you depressed? Are you having any negative thoughts? Yes. If the answer is yes, take it very seriously. Let it not go. Do not leave the suicidal survivor alone if there is an immediate danger, or else we'll feel guilty later on. So let us give her a proper support. Always consult a supervisor about how to refer or manage a suicidal survivor. Never make a decision on your own. Let us not take our own decision single-handed. Let us involve more people. This is for your own safety and well-being. Yes, provide a referral to GBV expert. GBV is Gender Biased Violence Agency, or OSC, which is Crisis Single One Station Crisis, for additional help if possible. Obgyns should not ask survivors about suicidal thoughts or attempts. It should encourage suicide attempts. Is it true or false? We all know the answers. Now please post your answers in the chat box. False. Ask about suicidal attempts or thoughts does not increase the suicidal attempts. On the contrary, talking about suicide often reduces the woman's anxiety about the suicidal thoughts and helps her feel understood. That's why we have to be very compassionate towards her, and definitely we have to support her and ask her be more empathetic. If the survivor tells you that their abuser has threatened to harm them, then what should you do? Put your answer in the chat box again. Let us have the interaction. What are you thinking about this? I will tell you the few ideas. Now, what should we do? Ask concrete questions about safety risks, but only when there is privacy. So when we counsel the women, there should always be a privacy. Nobody should be interrupting. And as Dr. Raki told how to counsel, we have to counsel the woman properly, looking into her eyes with open hands and modified tone. So ask if survivor has a safety plan in place in case she needs to flee. Discuss potential strategies for being able to leave her situation safely. Provide a referral to a GBV expert agency or OSC, that is One Stop Crisis Center, for additional help if necessary. So don't get involved single-handedly and don't take care of it. You have to involve more people, the counselors and GBV experts, and one-stop crisis management. One of the most helpful techniques for helping the survivor to get out of this emotional state is to ask them closed-end questions that require them to think. So what are closed-end questions, closed-ended questions, and what are open questions? Let us see about it. Closed-end questions, the answer is ready. It will come in single word, that is yes or no. Whereas open-ended question, it means her thoughts will get involved and she will have to answer in many words and put it properly in an answer. So shifts them from one emotional state to a cognitive state. Okay. Should require short answers. The close-ended questions now we are talking about, do not return to open-ended questions unless the survivor feels comfortable and has some degree of emotional control. So initially we start with close-ended questions and later on we should come to the open-ended questions. What are some examples of close-ended questions that you might go to in a situation like this? Ideas in the chat. For example, these are the closed-ended questions. How many kids do you have? How are you? How are they in school right now? What are the ages and the personal questions like that to get more attachment towards the women. Challenging issues when dealing with a survivor who may be mentally ill. Already Ramani madam told us about the mental issues that a woman will face. Let us see few of them. State clearly who you are and what your role is. So you have to clearly explain your role, how you can help her. Be empathetic towards her. Be empathetic, non-threatening, sincere in your intention to help, and let us not be judgmental. Give honest, factual answers whenever necessary. If you do not know, say so. Just say, I don't know. Do not belittle concerns which the survivor raises. Do not give advices as to handle of their psychological problems. Attempt to be supportive in comments and gestures. Do not assume mentally ill people should know better, or on the other hand, that they need to be told what to do. Be careful about making any assumptions. Know how to activate emergency mental health backup. That is more important. So you have to bring down your knowledge, get into the woman level and speak to her in an open way. Additional challenges, issues. What do you think? Can you be a part of meditation process? Remember, meditation is not recommended as response to GBV. Yes, because we should not subdue the woman and say you're facing, you have to undergo all this and you can tolerate violence. Don't give such answers and don't let her understand that is right. Remember, health workers are part of a survivor-centered referral mechanism because we all are the first contacts. The women will come to us thinking us as a friend who can confide in us. So we have to properly guide us what to do, what not to do. The meditation process itself maintains and contributes to an abuser's ongoing power and control over the survivor. The abuser may think she's more subdued, she's calm, I can do more. No. The process of meditation presumes that both parties can speak freely, confidently, and safely. That is not the case. Meditation rarely results in an end to the abuser's violence and can actually lead to an increase in violence. That's what I told you. It's unlikely that the survivor's rights will be respected. So being calm and tolerating everything is not the answer. Core safety precautions when dealing with challenging issues or cases. Multiple people can handle difficulty better, more effectively than one person. We have to involve more people, as we thought, the counselors, the one-stop crisis people, whoever are there, whoever are available, and the experts. A service provider should never feel like he must work alone with the survivor. The service provider should not work with both the perpetrator and survivor, not at the same time. Keep the office door open of leaving the office or home if feeling unsafe. Yes, keep the doors open. Establishing a code, like a code word with co-workers to identify unsafe situations, and you have to speak out the code word so that everyone will come and help us. Establish a relationship with local police or security. Use buddy system at work. Yes, have a WhatsApp group and immediately alert them if you are in danger, and to and from work, and if doing some home visits. So use supervision to address security concerns. A group of people can address security more effectively than an individual. So always being in group is more important, and communicating, helping the women in group is important. Coming to the self-care for the provider, it is critical for you. Yes. What can we do? Do you know what is vicarious trauma? Put your comments in the chat box, please. Yes or no. Do you know what is vicarious trauma? Let us see what it is. As a service provider, you should be aware of it for self-care. Defining vicarious trauma. So let us know what is vicarious trauma. A change in a service provider's inner space as a result of emotional engagement with survivors of trauma and hearing their stories. Yes, when we continuously have such stories, listening to them, getting involved with them, we ourselves might get affected. We become more depressed. Why is this happening? We should not go in a negative way. We should be mentally stable, accept it and analyze it. Changes that occur in the service provider's physical, emotional, or behavioral states as a result of constant exposure to the traumatic stories or events. This should be handled properly. When we were doing duties at government maternity hospital, which comes under Osmania Medical College, during every duty, we used to have these rape cases. It was really haunting, very terrible. Few months we used to have that going on in our brain. So it was very, very difficult. We should be definitely strong and analyze the situation, and we can see how we can help them. Coming to the causes of vicarious trauma, constant exposures to stories of trauma, desire to help change survivor's situation, feeling powerless when a service provider does not see positive changes in a survivor's situation, identifying with survivors, thinking that the service providers has the power to change a survivor's situation. This is not the case in every case. Maybe we can be empathetic, but cannot always help them. Preventing and managing vicarious trauma. The mnemonic ABC should be remembered. A, awareness, being attuned to one's needs, limits, emotions, and resources. Practice self-acceptance. Balance, maintaining balance among activities, especially work, play, and rest in the family. Connection, maintaining supportive relationships. Communication is a part of connection and breaks the silence of acknowledged pain. These connections help prevent isolation and increase validation and hope. So definitely the communication is good. Self-care for health provider. Creating boundaries in the workplace, establishing support within the work environment, like having good friends whom you can rely on, and definitely they will give a good support. Seeking assistance from outside agencies, creating our own self-care plans and following them through. So we should have a strategy to help ourselves and the survivor also. Empathy versus sympathy. So let us see what do we understand by saying empathy or sympathy, and which is better. Pick which statement describes sympathy and which statement describes empathy. Statement 1. A personal emotional identification with the survivor's experience and implies that the service provider feels sorry for the survivor. It is an emotional state that leaves the service provider vulnerable to over-involvement and can take power away from the survivor. This is what? Empathy or sympathy? Please guess. And statement 2, an intellectual personal understanding and realistic professional distance. It involves compassion and objectivity and leaves room for empowerment of the survivor. So you please put it in the chat box, which is empathy and which is sympathy. We'll see who is correct. Sympathy is personal, emotional identification with the survivor's experience and implies that the service provider feels sorry for the survivor. It is an emotional state that leaves the service provider vulnerable to over-involvement and can take power away from the survivor. So we have to understand this. It is identifying with the survivor's experience through your own shoes. What is empathy? Empathy implies intellectual personal understanding and realistic professional distance. It involves compassion and objectivity and leaves room for empowerment of the survivor. Now you understand what is empathy, sympathy, and which is good. Sympathy is better or empathy is better? Always empathy is better. It is the attempt to put oneself in survivor's shoes. So how do you take care of yourself? Please put it in the chat box and let us see how we are going to put up in such a situations, how you're going to act and find answers for you, and how you can act and come out of it. Please use some relaxation and self-care techniques and put it in the chat box so that we can spread.
That is such a powerful, sorry, go on, sorry.
Registration and pre-test, post-test and feedback are very, very important. The certificate will be awarded to participants on course attendance and submission of registration, pre-test, post-test and feedback. Thank you so much.
Yeah, I think please bear with us with this pronunciation, which should have been mediation. I think the thought process related to mediation has come out very clearly that we do not have a strong role to play over there because it could lead to some other consequences for which we are not ready and should not be ready for the same. Having said that, this was a very important topic for all of us over here because, many a times in the, our busy schedules and our practices day in and day out, we do not realize what is it that each one of us goes through. And, many a times we internalize whatever we are seeing and experiencing. And therefore, the differentiation between sympathy and empathy becomes that much more critical for us to take cognizance of those facts and taking forward the processes for ourselves. We didn't see many responses on what do you all do as your own relaxation techniques, or what is it that you do? Can we have some responses over there? What is it that you do as part of your relaxation and your mental de-stress techniques? Would love to have that. In the meantime, we have Anita here, who will be walking us through the next presentation.
Thank you, sir.
Okay.
Thank you.
Yeah,
Thank
and while the topic that Anita will be presenting in terms of support system, which is available to the survivors, there are a lot of, towards the end of the presentation, there are a lot of, phone numbers from various states and all of that. So we will not be going through each one of them. We will be skipping all of that. Needless to say that all those numbers are available with us, and we will be sharing these presentations to you. And when you have to take these sessions in your societies, or when we involve you in taking sessions in other societies, we will, relevant to that state, only those slides you can go ahead and present. But for today, we will just skip through those portions. Is that fine, Anita? Because
Yes,
it's
sir. Yes,
repetitive, it will not be relevant. Everybody
Yes,
needs
yes.
to know that it is available. Oh,
Yes,
that's so wonderful to hear. So many people writing lovely messages of what you all do.
Okay.
Music, hobbies, exercise, meet the loved one, and meditation, deep breathing, walking, perfect, being with nature. It's really wonderful to see all of that happening here. And in these COVID times, which, it has been doubly stressful for all of us with the workload that we have. So it's good to see that each one of you is practicing something or the other. Keep at it, keep going at it, because that's important for our own mental health and well-being. Over to you, Anita, please.
Thank you, sir. Thank you so much. And good evening, everyone. And to begin with, I must thank our President, Dr. Shanta Kumari, as well as Ajay, sir, for really giving us the opportunity to be part of this great group. And before I go on with the support system and resources for the survivor, as Ajay sir was asking all the audience, what are the ways of relaxation? So I must say, at the moment also, sir, we are having a relaxation party going on over here. We are celebrating Mother's Day tomorrow. So in advance, happy Mother's Day to everybody. So my group over here from Delhi is here. We are in one of our Foxy members' house, and they are having the practice for the dance and the singing for tomorrow's function. So that is one very big way of having relaxation for us. So now I can go on with the support system and resources for the survivor, which make a very, very important part, and they really go a long way in helping the survivor. So what is everything about it. I will talk about it in these coming slides. So there are various protective laws and acts which have come into action, which help these survivors. And we have various helplines. We have what are OSCCs, that is one-stop crisis centers, which we were just talking about, and also how we can link up everything so that we can help rehabilitation of the survivors. So for that, we have the protection of women from domestic violence. We have this Act 2005, and it's called Protection of Women from Domestic Violence, and it extends to whole of India, and except state of Jammu and Kashmir, which also will come into force and which will be known to everybody soon. Now, why this act has come into force, Domestic Violence Act 2005? Because we had 490A into the Indian Penal Code, which was introduced in year 1983. But in that, there was no emergency relief which was available to the victim or the survivor. And the remedies available were linked only to the matrimonial proceedings. And therefore, the court proceedings were always very prolonged, protracted. And they were so long, like we say, tariq pe tariq. So during that period, the victim was invariably at the mercy of the abuser. And also in this 498A, relationships which were outside marriage, they were not recognized. So now why Domestic Violence Act 2005 came into force? Because this is a civil law. In 498, the husband is liable for punishment, but wife does not get any financial relief. But whereas in domestic violence, the wife or female partner also gets relief, and there is no punishment and arrest of the husband unless he violates the court order. So in that case, there is a non-bailable warrant issued for the husband if he doesn't obey the order. Then another difference is that 498A can be booked against husband or his relatives, whether they are male or female, all. But domestic violence can be booked only against the male members of the family of the husband. So now who can be a complainant as per this 2005 Domestic Violence Act? The complainant can be a wife, or it can be also a woman based on the consanguinity, marriage, adoption and cohabitation against a male abuser in a shared household. So also a woman who is in relationship similar to a marriage with a man. Technically, even a transgender male to female could also bring an action against a transgender female to male. And also a woman in a live-in relationship, because this has been now legalized. And if she's in live-in relationship with an unmarried man, but not with a man who's married, if she knew or ought to have known that he was married. So in that case also, she can be a complainant. And also this complaint can be filed with the survivor's consent by anybody on her behalf. So these are the things which happened in this act. And now who can this person complain to? So previously we were just talking that go to police or you go to magistrate. We knew these two people. But under this act, you can go to a medical officer in charge. Then you can go, there are service providing centers which have been enacted now. And also you have protection officers, again by our government of India, by the Department of Women and Family Welfare, Social Welfare. These protection officers are there. And we know these protection officers you can contact even by going to police station. You can just ask them to connect to them, or you can go to Women Commission. You can ask them. There is a big list of all these officers and you can get connected, and they're supposed to help you in all ways. So where can you complain? What is the jurisdiction under this act? So this also has been made very convenient and easy for the woman survivor, because here the wife, where she stays permanently, or she's residing temporarily, or she's carrying on a business, or she's employed with, she can go and complain in that area. Or she can also complain where her husband is permanently residing, or whether he's residing temporarily, or he's carrying on his business or is employed. Or in third case, she can have a complaint where in that area where this action, where this problem, the violence has taken place. So in that place also she can go and complain. Now she has these three options. Now it's up to her, whichever option is convenient to her, she can utilize that and she can go and utilize that jurisdiction. So now there are types of orders. What all orders can be passed when you go and complain? So what kind of reliefs you get? So the woman survivor can get protection order for her protection and safety. And the orders can be passed to stop violence against her and to give her emergency relief. And also the order for residence in a shared household, whether she has any right of ownership or not, or any lease over there, still they can be given order to give her residence. And she can also require a separate housing, and abuser has to provide this. This also comes under this order. And also she can be given a custody order for the children. And then also the compensation order, the money relief which can be given to her. And also if the person, the husband or the perpetrator is violating all the above orders, then the magistrate will make it as a charge and can pass a non-bailable warrant against the person. And then this again, the same thing, the non-compliance of a protection order by a magistrate can lead to issuance of non-bailable warrant. So that is why this has been made very nice for the woman survivor. Now, again, the time also, if you just go time prescribed by this act, as we said that in the previous 498 used to be a very prolonged one. And by the time people used to get so fed up, the woman and the family would get so fed up. But this act requires all proceedings which are brought under this be disposed of within 60 days of the first hearing. And that first hearing has to happen within 3 days after you apply for it. So you just go and apply today. Within 3 days, you will be heard, and within 60 days of that first hearing, the case has to be disposed of. So this is a very good thing about this act. And now what are the services which are offered under this act? That you get the service of filing a detailed investigation report, and also direct complainant to a shelter. So she will get the facilities of a shelter during that period. And also she will be facilitated to get free legal services. And also she would be provided counseling services as required by the survivor. So now we have just heard about the Protection of Women from Domestic Violence Act, that is called PWDVA 2005. Now we have the latest, but before that, the other domestic legal remedies in India are, as we all know, the Constitution of India gives us as per Article 14 on equality. Then the National Commission for Women set up as a statutory body in Jan 1992 under the National Commission for Women Act 90. And then we also have, everybody knows, the Dowry Prohibition Act and the 498, which I just discussed, IPC. This is the most widely used provision against domestic violence. But now we have the latest, this which we just talked about, PWDVA 2005. I'm sure you all will agree that we have really got a lot of positive things out of this act. Now, the support system, which is really the need of the hour, we have the concept of one-stop crisis centers. And they cater to the immediate medical, legal, and psychological needs of the women who are the survivors of this physical and mental abuse, with an assurance that their consent, their confidentiality, they all will be respected as well as protected. So these are very, very women-friendly centers, and they give comprehensive help. She doesn't have to run from pillar to post. So one place she goes to, and she is looked after in a very friendly manner. Like you can see here, Goravi, which is at Madhya Pradesh. It is a joint initiative of Department of Public Health and Family Welfare, Government of Madhya Pradesh. And Action Aid is supported by the Police Department. So Goravi staff of 10, there are 10 people in that. They focus on the victim's need without compartmentalizing any services. So this was started in June 2014. So similarly, we have at other places, you can see here, Bharosa Trust. You can see our president, Dr. Shanta Kumari over here, along with other teams. So Bharosa Center and She Team's office. This is in Hyderabad, all in one for violence against women, with police, with counselors, with psychologists, with legal advisor, with medical help, whatever is required for the survivor at that moment. And their helpline is 100 and will be directed to Bharosa if it's violence. A woman can walk in with the assurance, again, as we just mentioned, that her consent, her confidentiality, all will be protected as well as respected. So this is what the women expect and they get over here. So what are these one-stop crisis centers? Ultimately, what kind of services they provide? They give, safe custody and shelter home. They rehabilitate the woman, give psychosocial counseling, social welfare services, the legal support, police assistance, her medical treatment, her forensic DNA test, all under one roof are done over here. So there's many such many such centers. So you can approach All India Women Helpline, Women in Distress. So these numbers are there. In the next few slides, I'll be just displaying 1091 and Women's Domestic Abuse Helpline 181, National Commission for Women. All these numbers are here in Delhi, Commission for Women, Outer Delhi. So all different NGOs, local champions, police stations. So in your local city, you will find these helpline numbers. So then after finding out, you can share them with your people who require them in groups or schools or wherever. So if you just see, we have so many, maybe 234 such centers, and like Andhra Pradesh you have, so every state of a country and every union territory of a country, they all have these centers. Only thing is we have to know them, we have to know how to approach them, we have to know their communication numbers, and then we have to tell our people, because if they are aware, they know they have such services, so they will easily like to go over there and utilize these services. So you can just see here, Andhra, Arunachal, Andaman, Nicobar, Bihar, all these places, Chhattisgarh, Daman Diu, and Dadra Nagar Haveli, everywhere. There's one Jagori Safety Center and National Commission for Women in Goa also, Delhi also. So all these places. So all helpline numbers that they will help you, and they are there in every state and UT. So I'll just take the names: Gujarat, Himachal Pradesh, Jharkhand, Jammu Kashmir, Karnataka, Kerala. Kerala, you can see Bodhini and Vanita helpline, number of Kerala police. Maharashtra, you have so many: Mumbai Railway Police, Women Helpline, Women Commission, and Women Helpline, Majlis, Navi Mumbai. So they're all from Mumbai. And then you also have the Manipur. Again, some helplines you will find common numbers like 181, whether in Manipur or in Mizoram or in Nagaland. So all these numbers are there, which you can just see on the screen. And even in Odisha, see in the previous slide also we were seeing 181. Here also they're common to various places. Odisha also you have 181, Puducherry, and Punjab they have different helpline numbers like 1091 and 112. And then in Chandigarh, Women Helpline again is similar to that Punjab. And in Haryana you have 181. Rajasthan again, like Punjab, you have 1091 and also 1090. And then Tamil Nadu and Tamil Nadu State Commission, Women Helpline, Telangana, Tripura Commission for Women, Uttarakhand, Uttar Pradesh Women Commission, so Women Helpline. So you can just have a look here. So 1090 or 1091 or 1092 or 183. So again, towards the end, we are coming West Bengal Women Commission. So they have their timings, they have their website, they have their telephone numbers. So all these places are available in our country. So then I think so this is the best support which a woman can get, and we can really help her a lot if she reaches these centers well in time. So thank you so much for the patient hearing. And again, the last slide for every speaker: registration, pre-test, post-test, and feedback mandatory. And certificate will be awarded to all the participants on course attendance and submission of registration, pre-test, post-test, and feedback. Thank you so much.
Yeah, thank you so much, Anita. That was such a difficult and verbose topic. You made it so easy. Because many times these things are too it's too much to take in, but yes, you made it wonderfully simple for all of us. Yashodhara, We will try to put it on the Foxy website, but that is not within our hands. But we'll try our level best. If nothing else, the slides, if they can be made available on the Foxy website itself, is going to be great. And we'll try our level best. With that, we move on to how to do the submission of registration, any procedure. Registration related to what? We are not sure, Manisha. So we'll address that a little later, Manisha. You can put it in the chat box. And then we move on to our next speaker, which is Jyoti. Thank you very much for joining us, Jyoti, after a wonderful, wonderful program of the AICOG, which was held in Indore. It was, absolute delight to be there in the cleanest city of the country with the most wonderful program that was held out there. Yeah. Okay, Sangeet, Manisha, regarding the certificate, see, registration and pre-test, you have already completed it. That's the reason why you are here. And at the end of the session, my colleague here, Sriman, will be posting the post-test and feedback. So just click on the link, submit the two, and you are all set to receive the certificate as the master trainer for the obstetrician and gynecological Dheera program. Yeah, with that, Anita, it's over to you.
Sir, kindly
Sriman, please.
let me share the screen, sir.
Yeah, host, please, co-host. Sriman? Yeah, okay, you're co-host now.
Am I able? The screen is visible.
Yeah, we can see the screen, take it full screen, and we are set. Yes, we can see it now. Please carry on.
So thank you very much for this initiative. I'm much thankful to our President Dr. Shanta Kumari Madam and Dr. Ajay sir and all my co-master trainer. This is actually very nice thought about to induct the doctors and the general public, because these are the topics in common, means in the routine days we don't talk about that. Even in our families we don't talk about that. So this training must be a useful training for all of us. So we should be co-versed with all the words and all the phrases and all the things for to teach to our colleagues, to our patients and to their families. So today's my topic is sexual violence, how to approach a woman facing sexual violence. So there is the definition of the sexual violence. It refers to any sexual act or attempt to obtain a sexual act or unwanted sexual comments or acts to traffic that are directed against a person's sexuality using coercion by anyone, regardless of their relationship to the victim in any setting, including at home or at work. In simplified manner, nobody can do violence on a woman, being a husband or a neighbor or a live-in relationship partner or anyone. Rape is the term that is commonly used for the first type of sexual violence mentioned, forced or coerced intercourse, whose definition of sexual violence includes rape, but it is not limited to rape only, which is defined as physically forced or otherwise coerced penetration of vulva or anus using a penis, other body parts, or an object. In general, the people think rape is the only sexual violence, but no, rape is one kind of sexual violence, not in the whole. Facts about sexual violence. Chances are you know someone who has been sexually assaulted anywhere, in your neighborhood, in your workplace, in your family. Victims are usually know their assaulters. Sometimes they know the assaulter, but they are fearful, they are feeling guilty, they are feeling shame, so they will not tell the names. Victims are never at fault for a sexual assault. We have to assure and we have to induce our people that victims are never at fault, so should not feel the guilty. Rape is the least reported and convicted violent crime in the world. Sexual violence is preventable and help is always available. So these are the chart for the forms and context of sexual violence. There is a wide range of sexually violent acts that can be taken place in various circumstances and settings. There is a rape within marriage or dating relationships, rape by strangers, systematic rape during armed conflicts, unwanted sexual advances or sexual harassments, including demanding sex in return for favors, sexual abuse of mentally or physically disabled or challenged people, sexually abuse of children. So first three things, rape within marriage or without marriage, rape by strangers, and systematic rape. These are the things we commonly see. The rest of the three are little unusual, but the fourth number is usually seen in the workplace, but females are very fearful to note down these things or the complaint about these things. Sexual abuse of mentally and physically disabled people are very less reported, and sexual abuse of children are still in a very less number for reporting. There are forced marriage or cohabitation, including the marriage of children, denial of the right to use contraceptive or to adopt other measures to protect against sexually transmitted disease, forced abortion, violent acts against the sexually integrity of women, including female genital mutilation, obligatory inspection for virginity, forced prostitution and trafficking of people for the purpose of sexual exploitation. These all things also called the sexual violence. Forced abortion, when we are floating these slides in all the master training session, many are asking forced abortion is as a sexual violence. Yes, forced abortion is the sexual violent act. So what are the customary forms of sexual violence? Like child marriage. Marriage is often used to legitimize a range of forms of sexual violence against women. Marrying of young children, particularly girls, in the many parts of the world is a customary form of sexual violence. It is legal in many countries in the form of sexual violence. Children involved unable to give or withhold their consent. So this could be and this can be titled as a rape. Majority of them know little or nothing about sex before they are married. The consequences of sexual violence is pregnancy and gynecological complications, sexually transmitted diseases, mental health issues, suicidal behavior, and social ostracization. Fatal outcomes related to sexual violence are suicide, homicides, AIDS related. And non-fatal outcomes related to sexual violence, these are some physical consequences like unwanted pregnancy, infertility, sexual dysfunction, chronic pelvic pain, sexually transmitted infection including HIV or AIDS, obesity or anorexia, UTIs, GI tract disorders, gynecological and pregnancy complications, migraines and other frequent headaches, fatigue and nausea. Some rape trauma syndrome, post-traumatic stress disorder, social phobias, shock, increased substance use or abuse, denial, fear, confusion, anxiety, guilty, depression, alienation, and eating disorders. The list is so long. And whenever you see some patient who is complaining about some of these things and there is no link to other diseases, do ask her in a respectful manner if she is going through some trauma like a sexual violence. Approach to survivor of sexual assault. Sexual assault is one of the most invasive and intimidating form of violence. A trauma-enforced care approach should be utilized. It involves through understanding of neurological, biological, psychological, and social effects of trauma and violence on the individuals. When a patient presents and reports a sexual assault, triage the patient as a medical emergency. Don't make her feel guilty, don't make her feel shameful, and take it as an emergency. Immediate needs of a survivor of sexual assault. So first of all, medical or psychiatrical evaluation and stabilization of the patient should be done. Activation of community advocacy to the bedside. Mandated reported as directed by state stretchers. Offering and conducting, if desired by the survivor, the sexual assault forensic exam, it is called SAFE. Collaboration with law enforcement, if desired by the survivor. Prophylactic medication for STI and STDs. because sometimes rape is conducted by the unknown people, or when the woman is going alone in the roadside, some mishap is happen. It is the first priority to give the treatment for the STI or STDs. Pregnancy risk evaluation and care and safe discharge planning. Those providing medical and forensic care must always be prepared to provide testimony as either a fact or expert witness. Pregnancy risk evaluation nowadays is very important. It should become as a first care treatment, because unwanted pregnancy is the hazardous for the mental and physical health of the woman. Application of trauma-enforced care to the care of the patient discloses sexual assault. This first safety, then trustworthiness, then choice, then collaboration, and then empowerment. What is the safety features? Knock on the door and ask the permission to enter the patient's room. Already she is very going through the trauma. So first, give her a total respectful manner, total respect to the patient. Ask her before entering her room. Meet with the parents before they disrobe. Ask the patient to disrobe only when the necessary or only partially disrobe. Provide and clearly identify washrooms. Take time to familiarize the person with the physical environment. Ask about comfort level with lighting. Share control, show respect, use a warm and compassionate manner to build rapport. Sometimes they are young age patients, assaulters, and sometimes they are in the close family sexual violence victim. So take them in the full control. Full control means give them respect and make them familiar and make them very close to you so they can share their problems. Trustworthiness. Explain all procedures in terms the person can understand. Tell the person what to expect and how long it will take. Ask the person what he or she wants. Now, choice. Ask if you can touch them each time. Every time before touching, please ask. Ask before you invite in additional staff. If your staff is male, then you should ask. If your staff is female, make a trust. Ask if you can close the door. Allow the person to decide where to sit in the room. Choice should be the patient's choice, should be the priority. Explain rationale for each procedure, what the procedure will feel like, and make appropriate modifications to reduce re-traumatization. Obtain consent for each part of the exam performed. General consent should not be taken. When the patient is disrobed, ask the consent. When you are touching the private parts, ask the consent. Collaboration. Ask what are your top worries or concerns and address these first, if possible. If the patient concern is about the STDs or the pregnancy or the trauma, physical trauma, give full consent to that priorities. Share information. Encourage the person to make decision about the treatment. What she wants or he wants, give the choice to the person's will. Empowerment. Ask what happened to you, not what is wrong with you. Never ask why. These questions, as they imply fault of the patient. Take time with the person so he or she feel genuinely heard. Ask if the person has preferences related to or has had difficulty with the particular procedure. If she is uncomfortable, don't do at that particular time. Ask the person what you should know before you begin the procedure. Ask if there is a way you can make the procedure easier for him or her. Ask if there is a way you can make the person relax, like a different position. Pay attention to body cues. Many survivors have been conditioned to be passive and defer to authority, and so may not disclose distress during a procedure. Elements of the essay history. Medical history, recent consensual sexual activity, assault-related medical history, sexual assault details, nature of the physical assault, post-assault activities, suspect information. Post-assault activities including the washing of the cloths or genitalia, or if it is the old enough, the treatment of the physical injuries also. So this is the end of my topic. I would like to stress upon the elements of essay history. Sometimes the patient reported after 1 or 2 weeks. So take her in the full faith and ask immediate and minute details of her sexual assault history. Do make awareness around your surroundings, so you cannot miss any single patient of sexual assault. Thank you very much. And this is the mandatory slide for registration and pre-post test and feedback. Let us know if you are having any doubt about this. Thank you, Ajay sir.
Thank you so much once again. Yashodhara, yes, you can arrange this program at your society level. And this is for everyone sitting here in this program. You can also ask any of the close by or neighboring societies whom you want them to join. So you can combine few societies, you can do it individually. Just fix the date, fix the time, and let us know the expected number of participants. Based on that, we'll allocate the Zoom. Based on that, we will involve you to take few lectures as faculty and give you other national faculty who can come and take the lectures. So go ahead, combine whatever needs to be done. We're there to support you. And with that, we come to the last presentation, which is by far the toughest one. But we are confident that we will, finish that in the next 10 to 15 minutes, and we should call it a day at the end of it. Thank you so much. Anita, over to you.
Yes, sir. Thank you so much, sir. Can you all see my slides?
Yes, we can. Make it full screen, that's all.
Yes, sir. It's full screen now. Yeah. So thank you so much, sir, Dr. Ajay, sir, for having so much confidence in me and giving me this part. So we now go to examination of survivor and collection of evidence, which is really, really very, very important, because here comes the role of a gynecologist who can really help and help the survivor get the justice. And, we can do a big, major role in that, because we can use important evidence of the crime and help judges understand, because they need the evidence. So they then can understand the physical and mental condition of the survivor. We can use the reports to corroborate the survivor's story and enhance its credibility. So offer primary, and at the same time, we can offer a primary level counseling, treatment, and referral for the physical and psychological sequelae, which the woman really needs at that time. So a gynecologist has a very, very major role for helping this woman. So, and that includes the medical examination, and which starts with the informed consent, which is very, very important. And we have to record her whole history. We have to document the injury, and ultimately we have to have evidence collection to know the nature of sexual violence, what is the time which has elapsed between the incident and examination, and whether survivor has taken bath or has washed herself after the incident, to know about the exact nature of crime. So we have to remember, 25 major points, 25 things we have to do, just to revise or to remember, because 1 to 11 are general instructions, and then comes informed consent, marks of identification, relevant medical and surgical history. After that, history of sexual violence, and what was the type of violence, and whether it was emotional abuse, etc. After the history, then we go on to general physical examination. After general physical, we do examination for injuries. And then after general injuries, we look at the external genitalia and do the detailed examination, and then do a systematic examination. And then 20 and 21, they are the part of evidence and sample collection, which is very, very important. And after all these, we give provisional medical opinion, and after the opinion, we give treatment, which is given, that has to be written. And then we write date and time of completion of examination. And after getting the final reports, we write final opinion. So these are the main 25 which we will be discussing now. So the first 11, where the general instructions are, each and every part is very important, because we can't take these 11 things also as such. So every word over here has a proper meaning, which has to be taken care of. So name of the hospital and the OPD number, the inpatient number, they are very important. And then the name of the person, the survivor, then whether daughter of or wife of or son of whatever is applicable, we have to write. We have to write complete address, then also write age as she has reported. And also, if we know the date of birth, we should mention it. And then sex, whether male, female, or others, or transgender, whatever is there, we have to write. Then what is the date and what is the exact time of arrival in the hospital, which is very important. And then after this, we have to mention the date and time of starting of the examination or commencement of examination. And also mention this survivor is brought by whom. So name and as well as signature of that person. And then the MLC number and the police station name, they also have to be mentioned very categorically. And now whether this patient has been brought is conscious or is coherent, oriented in time and place and person or not, this has to be mentioned. And then any physical, intellectual, or psychosocial disability, it has to be mentioned. And also we might be needing interpreters or special educators where the survivor has special needs, like if she has hearing or speech disability or any language barriers or intellectual or psychosocial disability, then they have to be included, and that has to be mentioned here. So these general instructions are also very, very special instructions because they have to be filled appropriately. And then comes 12th, the informed consent and marks of identification. So the consent has to be taken, and if the patient refuses to give, then we have to mention that she has not given us the consent, refused to give consent. So I, name of the person, daughter of or wife of, son of, hereby give my consent for medical examination, yes or no, mention it. For we have to take consent for different medical examination as well as for medical legal examination. Then also for consent for sample collection for both clinical as well as forensic examination. And so we have to mention whether she has given yes, or if she is not, then no. I also understand that as per law, the hospital is required to inform police, and this has been explained to me. So because she has to be told about it, because every such case has to be informed to police, and if you don't police, you will be penalized for that. Then I want the information to be revealed to the police that she can mention yes, or if she doesn't want that, also we have to write. And then I have understood the purpose and procedure of the examination, including the risks as well as the benefits, which are explained to me by the examining doctor. And my right to refuse the examination at any stage is there, but the consequence of such a refusal, including that my medical treatment will not be affected by this refusal, has also been explained. Because even if she refuses, the medical treatment has to be given appropriately. And all these things may be recorded. Contents of the above have been explained to me in this language, whether Hindi, English, whatever, we have to mention it here. With the help of a special educator, if that has been done, that has to be mentioned. And if special educator or interpreter or support person has helped, then his or her name along with his signatures, they have to be mentioned. I'm saying here because now for even PNDT, every page, whether I'm doing pregnancy test or the other ultrasound, we have to write all these details and even keep a even stamp over there. And everywhere we have to write our signatures. So this is very, very mandatory here, especially. And then comes the marks of identification. So we have to look in for any scar or mole, so mention it. And also along with that, left thumb impression must be taken. So after this 14th number comes relevant medical and surgical history. So we have to know whether onset of menarche, if the girl is there, has happened or not yet. Yes or no, we have to mention. If it has happened, then age of onset. And then menstrual history, that cycle length and duration. And also date of her last menstrual period. And also whether she had menstruation at the time of this incident or the violence. And menstruation at the time of examination is there or not. And was the survivor pregnant at the time of incident or not? And if yes, what is the duration of pregnancy in weeks, which has to be mentioned? And if it's not there, any contraception use is there, yes or no? And if she's using any contraception, then what is the method, which is whether copper T or she's using any pills, so that. And also the vaccination status, whether she has been vaccinated or not for tetanus or for hepatitis B, both. These have to be mentioned. And then we have to have the history of sexual violence. What is the time of incident, location, where it happened, what is the estimated duration, whether it happened within 1 to 7 days or within a week to 2 months, or 6 months. And then this episode was one or multiple, or if it is more than 6 months, then we'll say it was chronic, and whether it is known or not. Then how many people were there, number of assailants, then names if she knows, and the sex of the assailants, and what was the approximate age of those assailants, and if known, any relationship to the survivor, that has to be mentioned, and description of the incident in the words of narrator. And the narrator of the incident can be survivor herself or any other informant which is specific, with specific name and relationship to survivor, has to be mentioned. And if required in this description, extra page could be added if necessary. So this is very important. So this we are now going for the sexual violence part. So A is history of sexual violence, and now B will be type of physical violence used, if any. So here we have to see whether the patient has been hit by or has been burned with what, whether hand or fist or any blunt object or sharp object we have to mention in this box, whether there was biting, pinching or violent shaking or any other specific, any kicking or any pulling of hair, any banging of head or any dragging. So all these, tick the relevant answers and describe if any required. So that has to be mentioned. That also is very. And then emotional abuse or violence, if any, by insulting, cursing, violating or terrorizing. So they all come as part of the abuse. So any use of restraints on the survivor, any use or threat of use of weapon or any object, that has to be mentioned. Any verbal threats, for example, threats of killing or hurting the survivor, or killing or hurting of any other person survivor is interested in. Use of photographs of blackmailing, if any, or also luring her by sweets, chocolates, drinks or alcohol or drugs or money or job. So these things have to be mentioned, or any other specifics which she mentions, we have to write it over here in detail. And the D part is any history of alcohol or drug intoxication, whether she was sleeping or unconscious at the time of the incident. And E is if the survivor has also left any marks of injuries on the assailants, maybe somebody has given her some nail marks or something. So all these have to be noted. And then comes 15th F, that is the details regarding sexual violence. So after all this, was the penetration by the penis, or penetration was by fingers or any object or other body parts? So we have to write. If it's yes, write by, no, and then if you don't know, then write DNK. So like, which is the organ involved, like genitalia, whether vagina or urethra, or anus was involved, or mouth. And now it was penetrated by penis. So you have to mention here by body part of self or a salient. So any body part of self or of a salient or of third part, finger, tongue or any other part, or by object. And also we have to mention the emission of semen if it was there. So whether, if it is yes, then write here, no, write that. If they don't know, mention that. So this is very important again. And any details regarding sexual violence, again, forced masturbation of self by survivor, by masturbation of a salient by the survivor, manipulation of genitalia, exhibitionism, and then did ejaculation occur outside body orifice? And if yes, where on body? And any condom used? If yes, what was the status of the condom? Any lubricant used? If yes, describe the kind of lubricant. If object is used, describe the object. So these details have to be mentioned so that proper evidence could be given. And then post-incident details are very, very important, because with that also the evidence changes. If the survivor has changed clothes, or if she has changed the undergarments only, so we wouldn't know exactly, if the semen was there or not, all those things. And whether she has cleaned or washed her clothes, or washed her undergarments, she has taken baths, and so much evidence would have been lost with that. So we have to mention that she's done any douching, or she's passed urine, or passed her stools, or she's rinsed her mouth, brushing, she's vomited. So all, whatever is appropriate, if it is there, yes, no, we have to mention it. And also the time since incident incident and any other they should be mentioned, and also any history of vaginal, anal, oral discharge or bleeding since the incident of sexual violence, and also any painful urination, defecation, fissures, abdominal pain, pains in genitals or other parts since the incidents of sexual violence. Very important, that will tell us about the grievance of the assault. And then comes the general physical examination. We must take the height in centimeters and weight in kilograms and mention about the general build, whether thin, normal, obese, and what is her gait, and all the vitals have to be taken, and including pupils and any other disability or deformity has to be noted and mentioned and written appropriately. And then comes the examination of injuries on the body, because they can range from no injuries at all or they can be grievous injuries. So we have to know what kind of injuries, like whether they are bruises, any nail abrasions or teeth bites or cuts or lacerations, any fractures, any tenderness, any boils or burns, and where exactly from top to bottom we have to see whether scalp or face or neck, shoulders, breast, wrists, forearms, medial aspect of upper arms, thighs and buttocks. And then how do they look like? Size, shape, color, swelling, any sign of feeling, any simple or grievous dimensions, they all have to be mentioned because they also go a long way in making the diagnosis. We will know whether it is the remote or fresh. All these things will happen. And then we see the external genitalia and we have to do the recording of all this. So we start with labia majora, labia minora, urethral meatus and vestibule, foci and introitus, perineum and hymen. They all have to be examined and mentioned appropriately. But one thing we must be very clear about, that now per vaginal, per speculum examination is not allowed, should not be done, only if it is very, very urgently required to detect any injuries for the medical treatment. Only then they have to be performed. So ideally they are not to be done, but if we are doing it, then we have to write the findings and record the reasons for doing them. That is very important. But at the same time, the anus and rectum, they must be examined for any bleeding, and even including oral cavity for bleeding, tear, discharge, edema, or any tenderness. So these are very important parts of the examination, and we have to write them in detail. And then comes the systemic examination of central nervous system, cardiovascular system, respiratory system, and abdomen as per we go. And then is the very, very important part. After doing all the examination, we have to collect the evidence, and the sample collection has to be done. And because this will go a long way in giving her the justice to the survivor. So we have to obtain confirmation of allegation. By doing this, we have to establish the link between the victim and scene, and we have to establish the link between the victim and assailant. So every contact leaves a trace. So if we are very careful, very vigilant and systematic, and we see all these things in that manner, we shall not be able to miss anything. And we shall be feeling proud and happy to having helped the survivor. So the evidence collection, sample collection, always maintain the chain of evidence and identify the specimen, label the specimen is very important, and then sign the label and record the disposal of the specimen. So these things are very, very important. And then sample collection and investigations, and they are also of two types. One is at the level of the hospital laboratory or the clinical laboratory, and second is the central or the state forensic laboratory. The ones which we do in the hospital laboratory are blood for HIV, BDRL, hepatitis B, hepatitis C, and urine test for pregnancy, ultrasound for pregnancy or any internal injury, and X-ray for the injury. And the ones which go to Central State Forensic Laboratory are debris collection paper, clothing evidence where available, which have to be packed in separate paper bags after air drying. And sample collection, we have to take swabs from the stains on the body, like stains of blood, serum, foreign material. Scalp hair must be taken 10 to 15 strands, head hair combing, uh, would be done, and the stuff taken, nail scrapings, both hands separately, oral swab, blood for grouping, blood for testing for drugs and alcohol, and blood for DNA analysis. Then urine is also taken for drug testing, and any other tampon, sanitary napkin, or condom object is there that has to be taken as sample. And if we have not taken any sample, then it is not collected. So we have to give the reasons for not collecting. And then the genital and anal evidence, each sample has to be packed, sealed, and labeled separately. Then they have to be placed in a bag. So like matted pubic hair combing, mention if it's shaved, then you have not taken. Cutting of pubic hair, mention if it's shaved. And 2 vulval swabs, semen and for the semen and DNA. And 2 vaginal swabs, again for semen and 1 for DNA. And then 2 anal swabs, 1 for semen and 1 for DNA, and vaginal smear, which has to be air dried for semen examination. And then comes the urethral swab. And now all these samples have to preserve as directed till they are handed over to police along with duly attested sample seal. And if not collected, then we have to write the reasons why we have not collected them. And then comes, after all this collection, we have to give our provisional medical opinion that I have examined. We have to write name of the survivor, a male, female, or other, and the age, and then reporting type of sexual violence and circumstances, how many are number of hours or days or after the incident that we have to write, and whether she has had a bath or douched, and how many times since the incident. And my findings are as follows. You have to write samples are collected for forensic laboratory awaiting reports, samples collected for hospital laboratory, clinical findings are these, and additional observations are these. So they all have to be mentioned here one by one. And then after doing this, we have to give treatment, and we have given treatment, so we have to mention yes, not given, mention no, and any specific comments you must mention. So for sexually transmitted infection prevention, treatment has to be given, emergency contraception might be required, wound treatment, any tetanus prophylaxis, any hepatitis B vaccination, any post-exposure prophylaxis treatment for HIV, and counseling if done, or any other specific, we all must mention it over here in detail. And then after that, date and time of completion of examination has to be written, the date as well as the time of that day. And this report contains so many number of sheets, so they all have to be numbered and then written, and how many number of envelopes they have been put in, that number also has to be written, so that no evidence is missed. Then after that, you have the signature of the examining doctor as well as the name of the examining doctor, and one must apply the stamp or the seal over there. So then it becomes okay. And after that comes the final opinion, which is only after receiving the lab reports in the following mentioned formats, which we will have just now. And opinions regarding sexual assault, survivor has to be given in case of whether it is in case of assault or rape. So when you see the injuries on body parts and the spermatozoa, recent injuries, and you see spermatozoa are also recovered from vagina and they are motile, then we know there is evidence of recent sexual intercourse. But if we see partially healed injuries and non-motile spermatozoa and vagina when reported late, then it is sexual intercourse, but it is remote. And if we see local recent injuries to the genitals, but there are no spermatozoa recovered, and then we can say it's recent penetration, but it can also happen because there was condom used, or the male was vasectomized, or there was finger dildo used, or some other objects were used. And then comes evidence of remote penetration when local partially healed injuries to genitals are there, but we have not seen any spermatozoa. And also there is evidence of recent sexual assault. Sorry, it's written wrong here. If the recent injuries or bite marks are there at the neck, breast, nipple, thighs, etc., and but there are no other evidence there, but when help arrives before actual penetration occurs, so there we can mention this is recent sexual assault. Now, remote sexual assault is when there are partially healed injuries, bite marks, on the cheeks, breast, nipples, etc. But injuries to genitals are absent. So same that, but there the injuries were recent, and over here the injuries are partially healed. So again, this is a remote sexual assault, because we don't find injuries to the genitals, so that's why we are not saying that. And there is no evidence of vaginal penetration, but possibility cannot be ruled when there are no injuries, no spermatozoa recovered from vagina. But we can't say that, yeah, there is absolutely no vaginal assault or sexual assault, because there could be other reasons also. So there is no evidence of vaginal penetration, but possibility cannot be ruled out. That has to be mentioned. So these words are very important, which we must take into consideration. And then there is evidence of recent oral anal intercourse, like we just talked about the sexual intercourse. So same ways here, if you see the recent injuries and you see motile spermatozoa, and if you see partially healed injuries and non-motile spermatozoa, then we'll say it is remote oral anal intercourse. And same is for the penetration, as we just talked about. And there is no evidence of penetration, but possibility cannot be ruled out. Same here, when there is no injury, no spermatozoa recovered from oral cavity or the anal canal. So these are the main important things. So out of them, we have to see which one is fitting in this patient. So findings in support of the above opinion, taking into account the history, the clinical examination, the findings, the laboratory reports of whatever investigations we made, the identification marks described above, so many hours and so many days after the incident of sexual violence, I am of the opinion that one of those we have to mention, whether it is recent sexual assault or recent sexual intercourse, etc. So this is the finding ultimately we have to write. And after writing that, signature of the examining doctor, name of the examining doctor, place where it is happening, and the seal of the doctor has to be put here. And copy of this entire medical report must be given to the survivor or the victim free of cost immediately, which is very mandatory. So this has to be done. So ultimately, after going through all, we can summarize that whenever the victim comes to you, whenever the survivor comes to you, you have to take the informed consent. And we must note that per vaginal examination or the two-finger test, which was previously used to be done, is not to be done. Hymen or size of vagina, etc., is not to be commented. And it is to be done only when required for specific reason or for any injury documentation. And then comes the injury documentation. After that, we have to take the sample collection. And ultimately, after all the reports, we have to give the final opinion. So following are the components of comprehensive healthcare response to sexual violence and must be carried out in all cases. So we start with consent, then we go on to first aid of the survivor, then take history, do examination both for age estimation and physical, dental and radiological. And after examination, do evidence collection, and which has to be dry pack and sealed and then handed over to police, and along with documentation done. And after evidence collection, we have to give treatment for injuries, for STIs, test and treat and prophylaxis, HIV test and post-exposure prophylaxis, emergency contraception, urinary pregnancy test if applicable, counseling, information and referral to other services. And after giving this treatment, you can discharge the patient and ask her to come for a follow-up. So these are the various annexures we have. So for doing, as we all know, what all systems we require. So these are the tables you can see across what all things we require for doing the examination. So all these things are required. So whatever we have covered, so all the requirements, they are filled in these slides, annexures. So we acknowledge all the references, and we are really thankful to all the contributors, Srimati Swati Lakra IPS and Sumati IPS and Dr. Mamta Raghuveer, Dr. R. Sudha, and the Ops and Gynae Society of Hyderabad, and also the Sexual Assault and Medical Legal Care and of OGSH and Ministry of Health and Family Welfare, Government of India, for all the inputs. And so really we are thankful to everyone for contributing to this very, very important part of our this whole webinar, the examination of the survivor. So we come now to the end part of it. And again, I will repeat, registration and pre-test, post-test and feedback very mandatory. If you need certificates, after doing all this, you will get the certificate. So thank you so much for patient hearing. Thank you, sir.
No, we must thank you, Anita, because it is such a heavy topic, and coming at the end of the session, it's not very easy to remember all of that is there. You have said. I'm sure once we hand over the slides to each one of you, it will become that much more easy, and we'll try to see if it can go on the Foxy website also. So Jyoti and Anita, thank you once again. And each and every member of the core team, of which Anita and Jyoti are also part of the whole core team who designed and developed this entire curriculum for Foxians by the Foxians themselves. With that, Sriman has already posted the post-test link in your chat box. Please click on it, and you can, within the next 5 to 7 minutes, you can submit your your post test and your feedback. With that, we come to an end of this wonderful program, and each one of you have a lovely evening ahead of you and a very happy weekend to each one of you. Thank you so much.
Thank you so much, sir.
And happy Mother's Day to everyone, sir.
Yes, thank you so much. Happy Mother's Day to everyone.
Yes.
Thank
Happy
you for
Mother's
reminding
Day
me. I
Eve
need to
today.
call up my mom now.
Yes. Happy Mother's Day Eve today, and tomorrow we are all celebrating Happy Mother's Day at Delhi. You are all welcome to come to our Delhi Medical Association Hall in Dariaganj, Delhi.
Great.
5 p.m. onwards. Sir, come and join us. We'll have dinner
We'll
together.
try to do that. So everybody has got the.
Jyoti, you also come. Fly and come.
So, madam, please post the photos virtually. I will enjoy the dinner.
Sure. You know, I'm very good at that. My friends are here. Dr. Deepa, come. We are all having a rehearsal here for tomorrow's program.
Okay. Wonderful. All the very best, each one of you.
Thank you.
I hope everyone has got the post test now, are able to click on it. No issues. Then we can close the meeting, please.
Yes, sir. Thank you, sir.
Thank you, sir. Thank you, all the participants. All the participants, thank you.
And all the
Thank
very
you
best
very much.
for your program tomorrow, you and your team. Yeah.
Excuse me, sir. I haven't received the post test in my mail.
No, it is there in the chat box. Right now, you can click it.
Okay, sir. Please hold on. Then do not disconnect.
I'm posting it again.
Thank you, sir. Got it.
Got it? Great.
Yes.
Thank you, sir.
Now we can go.
Yes, now we can go.
Thank you.
Okay.
The volume is not a mental health.